Good afternoon, guys. I've got discussion A for you. We're doing the theme of this afternoon's show, contributors to senior falls. Okay, so be it medication, be it balance, we're gonna go through the whole gamut today for the presentation. So please join me in today's presentation A. Here we go. The article highlights a troubling trend. The tripling of fall the tripling of fall related deaths among older adults in the US over the past 30 years. And it points to classes of medication known as fall risks, increasing drugs, or FRIDs, as a major contributing factor. Here are some of the most commonly prescribed FRIDs associated with increased fall risks. Okay, common FRIDs implicated in senior falls: sedatives and hyponarcotics, drugs like benzodiazepines, e.g. lorazepam, diazepam, and sleep aids. E.g. zolpidem can impair coordination, slow reaction time, and cause dizziness. Antidepressants, especially triglycides and SSRIs, e.g. amtriptyline, fluoxetine, which may affect balance and blood pressure regulation. Antipsychotics used for dementia-related behaviors or severe mental health conditions. These can cause sedation and orthostatic hypotension. Antihypertensives, blood pressure medication, e.g. beta blockers, ACE inhibitors, may lead to lightheadedness or fainting, especially when standing up quickly. Opioid painkillers, drugs like Oxycontin and hydrocodone can cause sedation, confusion, and impaired motor function. Why it matters. Dr. Thomas A. Farley emphasizes that lifestyle changes alone can't explain the surge in fall deaths. Instead, the growing use of these medications among older adults, often in combination, may be a key driver. This raises urgent questions about prescribing practices, medication, reviews, and the need for culturally responsive prescribing strategies. Especially in marginalized communities where access to access to geriatric care may be limited. Would you like to explore how we might integrate this into a myth busting module or caregiver toolkit? I can help sketch that out, a participatory framework or evaluation guide tailored to your outreach goals. The section titled Falling Accidents and Injuries on the Cleveland Clinic page serves as a comprehensive guide to understanding, diagnosing, and treating and preventing fall related injuries across the lifespan. Here's a breakdown of its meaning based on the surrounding contents. What it means: falling accidents and injuries refers to the wide spectrum of physical harm that can result from a fall, ranging from harmless tumbles or stumbles to life threatening trauma. The page emphasizes that while anyone can fall, certain populations, especially toddlers and older adults, are at significantly higher risk for serious injury. Severity spectrum. The page categorizes fall outcomes into 4 levels: no harm, no injuries, just a scare; minor harm, which is bruises, small cuts, or mild sprains, usually manageable at home; moderate harm, injuries like larger laceration, broken ribs, or minor concussions requiring professional care. Major harm, medical emergencies such as hip fractures, traumatic brain injuries, or internal bleeding. High risk groups: children age 1 to 2, prone to falls due to development, mobility, and curiosity. Risks include stairs, windows, and playground equipment. Older adults vulnerable due to medical conditions, medication side effects, sensory decline, and environmental hazards. Falls in this group often lead to hospitalization, disability, or even death. Root causes. Falls can stem from medical issues, stroke, Parkinson's, dementia, frailty, vision loss, medications, especially sedatives, blood pressure meds, and opioids, sensory motor impairments, diabetic neuropathy, balance problems, environmental hazards, slippery floors, poor lighting, lack of grab bars, psychosocial factors, living alone, fear of falling, previous falls. Prevention strategies. The page stresses that most falls are preventable, especially at home. For older adults, regular checkups, physical activity, proper footwear, home safety assessments, and updated vision care. For children, supervision, child proofing, gates, locks, and early education about safety. Diagnosis and treatment. Healthcare providers use physical exams and imaging, x-rays, CT scans, MRIs to assess injuries. Treatment varies based on severity and underlying health conditions. Okay, next section, guys, is your guide to preventing falls. Live actively, age healthy. Okay, anchors at proactive, empowering framework aimed at older adults, caregivers, and health professionals. It's not just a slogan, it's a call to action rooted in evidence based strategies and holistic aging principles. The surrounding page content builds out this theme with a blend of practical advice, motivational messaging, and systems level thinking that aligns beautifully with your participatory and culturally responsive approaches. Okay, then the next section here, guys, is what the guide offers: a multi-domain toolkit. I'm going to go through that for you now. Okay, give me a second to get it. I'll back up a little bit so y'all can see me. Okay, this guide functions as a modular resource that integrates physical, environmental, and psychosocial dimensions of fall prevention. Tailored exercise regimens, balance and strength training routines are adapted for varying mobility levels, often incorporating progressive difficulty, and visual cues to support neuroplasticity. Environmental audits. Users are guided through home safety assessments with actionable suggestions like installing non slip mats, improving lighting, contrast, and rearranging furniture to create clear walk paths. Okay. Clinical check ins. The guide encourages regular reviews of medication, especially those affecting blood pressure or cognition, vision and hearing screenings, and chronic condition management, all of which intersect with fall risks. Psychosocial reliance. It addresses the emotional toll of falling or fear of falling off, offering strategies for rebuilding confidence, reducing isolation, and fostering peer support through group activities or digital communities. Live actively. Movement as medicine. This component reframes physical activity as a cornerstone of autonomy and vitality. Micro movements matter. Even brief, consistent movement, like standing during commercials or practicing heel toe walking, can recalibrate balance systems. Functional fitness. Exercise mimics Exercises mimic daily tasks, e.g., reaching, bending, transitioning from sit to standing, reinforcing muscle memory, and reducing reliance on assistive devices. Give me 2 seconds. Tech enabled engagement. Programs like Standing Tall use app based tracking, video demonstrations, and reminders to sustain motivation and adherence, especially for rural or homebound seniors or elders. Age healthy, a systems level view. Healthy aging is framed not as a passive process, but an active, adaptable journey. Nutrition and bone integrity. The guide promotes calcium rich foods, vitamin D supplementation, and hydration strategies to support musculoskeletal health. Cog- Cognitive scaffolding. It links fall prevention to executive function, encouraging sleep hygiene, mental stimulation, and stress reduction as protective factors, footwear and sensory input. Recommendations include wide-toed, non-slip shoes and regular uh, podiatric care, podiatrist care, along with vision correction and contrast enhancing home design. Empowerment through prevention, shifting the narrative. Rather than treating falls as an inevitable part of aging, the guide positions them as modifiable risks, self assessment tools, checklists, and uh, scrolling systems help individuals identify personal and environmental risk factors. Community integration, it promotes partnerships with local health centers, senior groups, and culturally specific outreach programs to ensure relevance and accessibility. Behavioral nudges. The guide uses motivational interviewing techniques and goal setting prompts to encourage sustained behavior changes. Would you like to co create a culturally adaptive version of this guide? Perhaps integrating intergenerational storytelling, trauma informed design, or rural infrastructure considerations. We could build a toolkit that resonates deeply with the lived experience of a specific community. Let's make fall prevention not just a practical but personal. Okay, so now, guys, this other section of the program today goes over 12 household hazards to get rid of after 70. Okay, and then we're going to go through purpose. The article emphasizes making the home safer and more comfortable for older adults, especially those over 70. Everyday items that once seemed harmless can become risky due to changes in mobility, vision, or balance. Key household items, key household hazards to eliminate. While the full list isn't shown in the preview, typical hazards often include loose rugs, uncluttered walkways, fall risks, poor lighting, visibility issues, step stools, ladders, fall danger, slippery bathroom surfaces, unstable furniture, extension cords, entangled wires, medication stored improperly, stroke detectors or smoke detectors of fire extinguishers that aren't up to date. Underlying message: proactive adjustments in the home environment can significantly reduce stress, prevent injuries, and support aging in place with dignity and safety. If you'd like, I can help you design a culturally responsive home safety checklist tailored to rural elders, caregivers, something that aligns with your toolkit work. Okay, guys, next section: 12 household hazards to get rid of after 70. I think I already did these. Okay, the last section here, guys, is study reveals 5 medication prescribing cascades that may put older adults at risk. Okay, so I'm going to do the last section here for you. So here we go. What are prescribing cascades? A prescribing cascade happens when a new medication is prescribed to treat the side effect of another drug. These cascades can be unintentional, especially when side effects are misinterpreted as new medical conditions. This leads to added risk for older adults, including unnecessary medications and potential harm. So, giving somebody a medication to counteract a side effect is not always a good idea, folks. Next page. Study review or study overview. Conducted by researchers at University College Cork in Ireland. Analyzed prescription data from over 533,000 Irish adults aged 65 between 2017 and 2020. Published in the Annual's Family Medicine magazine. Methodology: used prescription sequence, symmetry analysis within a 365-day window. Focused on 9 expert defined prescribing cascades known as think cascades. Okay, examined only examined only dispensed prescription data to identify patterns, implications, highlights the need for greater awareness among clinicians to prevent cascading prescriptions, suggests that older adults are particularly vulnerable due to polypharmacy and age-related changes in drug metabolism. If you'd like, I can help you explore how this might inform culturally responsive prescribing practices or toolkit adaptation for aging populations. A growing body of research is calling for urgent review of antidepressant use in aged care homes due to its link with increased fall risk among older adults. Here's a synthesis of the latest findings. Key findings from recent studies: high prevalence of psychotropic use. A study by uh, Macquarie University found that 40% of aged care residents were prescribed potentially inappropriate psychotropic medications, including antidepressants, antipsychotics, over a 2-year period. Fall-related consequences of those receiving such medications: 70% experienced at least one fall, and 1/3 required hospital transfer due to injuries like fractures or head trauma. Mechanism of risk. These medications affect the central nervous system, impairing balance and coordination, which heightens fall risks. Recommendations for safer practice: regular medication reviews. Researchers advocate for 6-monthly reviews using structured tools, e.g., prescribing algorithms to assess appropriateness of prescriptions. Team-based decision making. Successful interventions involved at least one prescriber from the residents' usual care team, ensuring continuity and personalized care. Non-pharmacological alternatives. Facilities are encouraged to explore exercise programs, environmental modifications like improved lighting and staff training to reduce fall risks. Implications for culturally responsive practice. Given their expertise, this opens up rich opportunity for toolkit adaptation, co-designing culturally tailored deprescribing. guides and fall assessment for diverse communities, myth busting outreach, addressing misconceptions about antidepressant use and aging through participatory education, evaluation matrix, mapping intervention success across different cultural and infra- infrastructural contexts. Would you like to explore how these findings could inform your caregiver toolkit or community engagement strategies? I can help draft a framework or case study. Okay, guys, so that's A for you. I will be back on with B shortly. Give me a bit to put that together for you, and I'll do another show for you with the information. So give me a little bit, please.